Kalau box ni aku beli.
Ya, bawah tak dekat sini.
Kalau nak point dia
Ni. Mak ni connect slide.
tekan dah tergerak. Gerakkan arrow. Ni arrow. Cuba gerak. Tekan point.
Ni?
Gerak. Ada.
Oh.
Betul itu.
Tapi kalau ni, boleh juga. Baik guna mak tu.
Tak apa.
Tak. Jadi macam.
Ya.
Kecuali boleh tunjuk ke sana. Eh. Ada.
Ini saya standby.
Ah.
Entah nak live YouTube. Ada sebanyak live YouTube. Ya. Betul kan?
Gerak yang mana tak? Oh, okey. Ya. Oh, jauh tapi macam jadi macam
Semua dekat yang depan. Apa dekat error. Jadi kan.
tapi macam
Mana buat kita?
ya bos. Itulah.
Kalau nak guna lah.
Kalau tidak guna ni ke?
Nak
Kan sama kan tidak kena. Ya. Benda ni je lah.
Ladies and gentlemen, we're about to begin shortly. Please be seated. Put your front seat and ensure your mobile phone as switching to silent mode. For attendance, kindly scan the QR code displayed on the screen. QR code is also available to sides of auditorium wall and entrance of the building. We will begin shortly. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning. We begin our CME today with Umar Kitab of Fatiha. It gives me a great pleasure to welcome the Examinability Trace host with the director, Dr. Nurhana binti Muhammad Fazil, Deputy Medical Director Training, as well as to our respected head of department, fellow clinicians, staff, and all members of the Sharif's Zakzul family. I'm Nurul Farahim binti Muhammad Nufin, MC from the. Welcome to today's emergency session, proudly brought to you by Medical Department. We are truly honored to have you join us for a topic that often remain in the shadows, yet deeply impact life: Parkinson's disease. Parkinson's disease is more than just a tremors and stiffness. It's a silent battle, a journey filled with uncertainty, courage, and the constant search for hope. And today, we are fortunate to have with us someone who's not just an expert, but a passionate advocate in this field, Dr. Saidatul Manira binti Muhammad. Now, please welcome to our speaker, Dr. Saidatul Manira, neurology specialist, who will be taking us on a meaningful journey to better understand Parkinson's disease, uncovering its hidden struggle and ongoing quest for intervention. Please welcome.
Assalamualaikum warahmatullahi wabarakatuh and good morning. So we actually very grateful that have an opportunity to get this date actually to give a CME regarding Parkinson's disease. Okay, why we choose in April? Because actually tomorrow is actually a World Parkinson Day. And this April month is actually a month for Parkinson awareness. Okay, we start with journey of the Parkinson disease. Parkinson disease is actually had been first described in 1817 by British physician named James Parkinson, and actually he 1817 until now, almost more than 200 years journey of Parkinson's, and it's actually over the 200 years. There is a multiple research have been done the better management in Parkinson. So based on WHO, actually the prevalence of Parkinson disease is actually doubled within the years. In 2019, it estimated about 8.5 million. Now 2025 is about already 10 million patients with Parkinson disease worldwide. So if we go through the 200 years of Parkinson disease, had been established disease, actually in 2020 is more towards the research for the better management and more management regarding the surgical approach, because we know that it's actually the management of Parkinson's disease is more towards the symptomatic therapy. There is no curative progressive neurological disorder. It's like a diabetes mellitus, chronic disease. And when we call it a progressive neurodegenerative disorder, it's related with our age. Okay, Parkinson's disease is actually second neurodegenerative disease because the first one is Alzheimer's disease, and it's actually among the movement disorder, the Parkinson's disease is the most common. Movement disorder ni include macam tremor, chorea, hemiplegismus, myoclonic, semua tu lah. Okay, what are the patients that having a risk factor to get a Parkinson's disease? Previously, Parkinson's disease we call is a idiopathic Parkinson's disease, means we don't know the cause. However, within the 200 years, a lot of study being done, research being done, there is a certain risk factor which is can predispose patient to get a Parkinson's disease. The risk factor that have been established towards the years, first is family history. Actually, the first gene mutation was done is 2017, and currently for the gene mutation and detection genetic study, we actually only done during the trials in a study population. We don't routinely do because it's very expensive. The other risk factor is for Parkinson's disease is age. So for those aged more than 60 years old, it's high risk to get a Parkinson disease. And the third one is environmental risk factor. Two studies had been published, 2015 and 2002. It said that first is toxin inhale or injection initiate to the our GI system is a risk factor to get Parkinson. The other one is actually for those that drinking well water is also risk factor to get a Parkinson disease. There are few certain protective factor have been studied. Yes, one of the protective factor is smoker, nicotine. So usually we don't routinely say to our population that is a one protective study because a lot of disease that come with a smoker and nicotine. So usually that we promote to our population, the protective factor for Parkinson disease is more towards the caffeine intake and also exercise. Okay. So we know the Parkinson disease is a neurodegenerative disorder. So where is actually the localization for the Parkinson disease? It's actually at the substantia nigra at the midbrain. So the pathophysiology is not at the substantia nigra at the midbrain also. It's also involved the pathway from the substantia nigra to the basal ganglions. And that when there is a degeneration of the pathway, it will cause a reduce of dopamine level in our brain. So when there is a reduced dopamine level in our brain, that's why the patient manifests with all the classic triad of the Parkinson disease. We call it a Parkinsonism. So this is complex pathophysiology of the Parkinson disease. It's actually what happened in the substantia nigra is reduce the excitatory motor cortex and also increase the inhibition of the reticulospinal tract. So that's why all the Parkinsonism features present in patients with Parkinson disease. Okay, when I talk about a Parkinsonism, so what are the Parkinsonism? Parkinsonism is mnemonic tract. T is for tremor, R for rigidity, A akinesia, P is posture or imbalance. So when patient is having all these clinical features, we say patient is having Parkinsonism. So in Parkinson disease, it's actually the Parkinsonism typically start on one side of the body. Then after a few years, ataupun with the time, the symptom is actually spread to the other side of the body. Okay. So this is a lady referred to us from the clinic kesihatan. Is actually already diagnosed to have a Parkinson disease. However, not tolerate the madopam. So when you see the patient, first the face is a hypomimia, mask-like faces. Then the hand is actually having a resting tremor. The resting tremor is only on the right side. So when the patient is presenting with tremor, we must evaluate whether this patient is having resting, postural, or intention tremor. So this is routinely been done at our clinics to establish whether this patient is truly having a resting tremor or other subtype of tremor. Okay, look at this uncle. So the face is not truly hypomimia because he still can smile. Okay. Then the hands, there is a resting tremor. So what is actually resting tremor? It's actually rhythmic involuntary movement, affected body when body is relaxed and supported by a surface area. So for in Parkinson disease, the tremor is usually asymmetric and it actually can affect also the jaw and also the lower limb. The second features of Parkinsonism is bradykinesia. The bradykinesia is not just slowness of the movement, reduce the movement, but also is the amplitude. So in the clinic, when we encounter patient of Parkinson disease, a few tests to decide whether this patient is having bradykinesia or not. So first testing is a finger opening. So when we look at the finger opening, so usually I compare the patient movement with myself. And hopefully I don't have a bradykinesia. So when we assess a bradykinesia, we don't assess the speed alone, but we also assess the amplitude. Okay, the other test other than finger opening is actually supination and pronation. Then the other test is we call a foot tapping or leg agility. So this test is actually to detect whether the patient is having bradykinesia or not. So can you really appreciate the video in this slide? So like this patient, first slow in initiation of movement. Second, the amplitude of the hand opening is actually become more smaller and smaller. Okay. Okay, I have another two video. So this patient, first see whether there is a resting tremor or not. Do you see? Right, left hand, there is a resting tremor. So far for the past 4 months, after I did to present on CME, I don't have a video for pill rolling tremor. I only have a resting tremor. Okay, see this patient video. So the speed is slow and the amplitude is become more reduced and reduced. So when we talk about the bradykinesia, it's not just a slowness of movement, but also the reduce of amplitude of the movement. So air dalam klinik sebesar selaju, pakcik masih sebesar selaju. Okay. So this lady, kalau tengok picture ni, nampak dia punya muka. It's actually mask-like faces, less facial expression, or in medical term we call it a hypomimia. So in this patient, is actually I want to show that the tremor is not involve the upper limb, but it also involve the left lower limb. Left lower limb. But it's just mild tremor. Okay. Okay. So now we clear that for Parkinson disease, first to diagnose is actually by presence of features Parkinsonism. Parkinsonism consists of TRAP, which is tremor, rigidity, akinesia, and postural imbalance. So usually patient was diagnosed once presented to us with a study. We know that it's actually Parkinson disease have a prodromal symptoms. The prodromal symptom is actually non-specific and it's not really towards a Parkinson disease. And some example of prodromal such as REM sleep behavior disorder when patient is acting out the dreams. Second, depression. So usually when patient was diagnosed with depression, so we don't think of Parkinson's disease at the first place. Probably we just diagnose patient to have depression. The other symptom, the most common is constipation or hyposmia and anxiety. Okay. At the meantime, since till 2025, there is no laboratory test to diagnose a Parkinson's disease. So to make a diagnosis of Parkinson's disease is actually first looking at the clinical features of Parkinsonism. Second is exclude the secondary Parkinsonism. Third is actually to see whether the patient is actually having good response to the medical treatment, which is levodopa. There is a multiple causes of secondary Parkinsonism. So when we see the patient, the history taking is important because from history we can exclude the secondary cause of Parkinsonism, such as the most common is actually drugs. Okay. The second one is actually metabolic or genetic, which is Wilson disease. Okay, so I prepared one. This is one of our patients. Mr. TRTM, 49 years old lady. She is our staff nurse at endoscopy unit. Actually, she presented to us on 2014. So actually already 11 years ago. So presented initially at the left upper limb and left lower limb tremor. No slow in movement, no family history of movement disorder or Parkinson's disease. She able to do her daily work and she able to do her daily work at the hostels normally. Deny any non-motor symptom, which is constipation, REM sleep behavior disorder, hallucination, and the memory examination. Even though patient just complained of the tremor, but during the examination, we noticed also she had a rigidity, cogwheel rigidity of the left upper limb. There is, and also when assess the gait, there is a reduced arm swing of the left side. However, there is no bradykinesia. So among the Parkinsonism features, the bradykinesia is the most important to diagnose a Parkinson's disease. So at this time, we don't diagnose her as a Parkinson's disease, first because of age. Second, there is no fulfillment of the full features of Parkinsonism. So we just manage the tremor first. So that's why we started on Aten. And because she is in the younger age, which is less than 50 years old, we need to search for the treatable cause of movement disorder, which is Wilson disease. So any patient presented with involuntary movement, less than 50 years old, first you must rule out is Wilson disease. Because Wilson disease is actually treatable cause. Rather than having a diagnosis of Parkinson's disease, it's just a symptomatic treatment. So we extensively work out for Wilson disease. We look at ophthalmology, noted to have a KF ring. That's why we extensively work out. However, after a few years, around 2 years, work up with 25 hours urine copper, serum celluloplasmin, because all the biochemically did not suggestive of Wilson disease. So this patient underwent a liver biopsy to determine whether there is a copper staining or not in the liver. The MRI also doesn't have any features to suggest of Parkinsonism, other causes of Parkinsonism. So at last, we actually conclude that this patient is actually having a young Parkinson's disease. Okay. So for progress for the past 10 years for this patient, in January 2015, about 3 months later, then only the bradykinesia was manifest. So at that time, okay, we conclude that this patient is having Parkinson's disease and was started with a dopaminergic therapy, which is pramipexole. However, patient cannot tolerate the pramipexole, then later was changed to ropinirole. However, why we choose a dopamine? Because it's actually a younger patient. Sedangkan the gold standard treatment for the Parkinson's disease is actually levodopa. So 1 year later, the symptom is actually worsening in terms of tremor. So we decide to start patient on levodopa base, which is Madopa. So over the years, so actually the symptom is actually worsening. So that is typical features of the Parkinson's disease. When upon diagnosis, we already explained to the patient, is actually the Parkinson disease is actually a neurodegenerative. Over the years, with the time, the symptom and sign is actually more worsening. So why we need to start treatment is actually to retard the progression of the Parkinson disease. So that's why Parkinson disease usually over the years, the treatment will be increases, add on. So that is the way of Parkinson disease management at the meantime. So until in January 2024, patients start to have a motor response complication. So when we start patient on levodopa base, we already expected that after 5 to 10 years, patient will have a motor response complication. So motor response complication for this patient, she has a frequent off. So because of frequent off, patient cannot able to come to work. So actually, we counsel patient with a DBS. That is the next step of management for the Parkinson disease. So after 3 months later, then she had a dyskinesia. So this patient, this video is taken during the admission for levodopa challenge test before we do a DBS. So you see this patient first. Slow initiation of movement when we asking to lift up the right hand. There is a tremor over the left hand. Okay. And looking at the right foot, there is a dystonia, spasm, muscle contraction over the right foot. The second video is actually when we asking the patient to stand and walk. So patient unable to stand by herself and walk by herself, she need a support from others to stand up. So rigid and so slow. Okay. So this patient, after that, is actually underwent a deep brain stimulation last year. So this video is actually similar with the previous video. The main symptoms that so troublesome to her is actually right foot dystonia and also all the symptoms of Parkinson's that causing he unable to walk and unable to work. Okay, so after the DBS, magic. So she can walk well. Actually, no reduced arm swing, no turn and block. Okay, so this is, I call her for this CME to get a latest video to show that how is she after almost 1 year of DBS. So first looking at the hand to look for Parkinsonism features. There is no tremor. This is I'm asking her name and age to look any slow monotonous speech. And looking also, is it there is any tremor or any dystonia of her foot? So during the finger opening, still noted that she have a bradykinesia, but only mild. The amplitude become more smaller during the finger opening. However, during the hand opening, the speed and the amplitude is looks normal. The supination and pronation also is good. Then we test for leg agility or hand, foot tapping. So, good kan? Okay. So, we recap balik the video before she underwent DBS. Unable to stand, unable to initiate movement fast, and unable to walk by herself. So this how she is walking now. So arm swing is good, no turn and block, easy to initiate the walking. Okay. So how amazing the latest management of Parkinson's disease. Okay, so as I said, diagnosis of Parkinson's disease is actually based on clinical finding only, based on features of Parkinsonism, which is tremor, rigidity, akinesia, and postural imbalance. Second one, we assess whether the patient is having response to levodopa or not. The MRI, usually if we memang confidently say, confidently that the patient is actually Parkinson's disease, we routinely do not order the MRI because MRI does not have much. Because we only do the MRI when we suspect the other causes of Parkinsonism. In a latest publication, the presence of swallowtail sign is only suggestive of Parkinsonism, Parkinson's disease. However, if there is no swallowtail sign on MRI, we still diagnose Parkinson's disease by a clinical diagnosis. And genetic testing is so expensive, 3,000. And usually we only do during the study or trials. And if patient requests, we can order, but the patient need to pay by themselves. Because I think when we do a genetic testing, it will not change our management. It's just untuk confirmation of the disease and also macam nak tell to the family members that they also have a risk factor, high risk to get a Parkinson's disease. So in Malaysia, we have a Persatuan Parkinson Malaysia, and we have a booklet. It's actually to give to the patient and also for them to read. Not only them, but also to the family members, to the caretaker, about the disease and also about the exercise or also medication to the patient. For patient is actually to have a reference for them. Because when we actually diagnose patient to have a Parkinson's disease, kalau patient educated patient, usually they will be disbelief, denial, fear and sadness. So some patient yang disbelief and deny, they ask us to get a second opinion. So we actually okay to refer to get a second opinion. So when I train at the HKL dengan UMMC, I get a second opinion referral from the USM, from the HRPZ. So usually the diagnosis is the same. Okay. So when we diagnose a Parkinson's disease, we need to explain to the patient, yes, this is no curative treatment, this is progressive disease, but we have a treatment to help them. It's actually to help them to reduce the symptom and for them to live with a normal daily activity and also can continue to work. And it's actually all the management is actually mutual understanding between the patient and us. So the Charter for Parkinson's Disease is actually launched in April 1997. It said that people with Parkinson's disease have the right to be referred to a doctor with a special interest in Parkinson's. So for the diagnosis, it's actually not only a neurologist will diagnose a Parkinson's disease, our FMS specialist also can diagnose a Parkinson's disease and then treat them. If the patient is not response or there is any macam doubt, then can be referred to us. So patient should receive an accurate diagnosis, have access to support the service, and receive continuation care and take part in managing of the illness. So the management is not only rely to the doctor to manage the Parkinson disease, but also depends on the patient preference. Okay, so for Parkinson disease, when we diagnose, we start the treatment. There is a maintenance treatment with dopaminergic therapy. When patient become having a motor response complication, we must consider an advanced therapy. But certain patients, yes, do become more progressive and become bedbound. Once become a bedbound, most likely we will more towards the palliative care. Okay, so for Parkinson disease stage of progression, we have early stage, mid stage, and late stage. So, early stage, we usually start a dopaminergic treatment. It's actually untuk reduce the symptoms and also untuk slow the progression and progressions. Okay, so based on our CPG Malaysia, when we decide to treat, so decision of treat is not depends on doctor managing the patient alone. It's actually discussion between the patient. So if the patient think that the symptoms and signs is not bother his or her daily activity, then usually we don't start the treatment. Okay, so if agree to start the treatment, then we must decide which one of the dopaminergic therapy that we want to use. So usually it depends on the age and also the severity of the motor Parkinsonism. So there is a few dopaminergic therapy nowadays available, which is levodopa based, dopamine agonist, MAO-B inhibitor, and COMT inhibitor. So all the dopaminergic therapy is actually to increase a dopamine in a substantia nigra so that improve the movement of patient in Parkinson disease. Okay, so in terms of management of dopaminergic therapy, the medication we start with low dose and go slow. So usually kalau macam Madopa ni, yang usually we will start with the 1/4 per day for 1 month, then slowly increasing to the maximum dose until 1 tablet per day. So a few dopaminergic therapy which consists of levodopa base. The most common use is Madopa. The other one is Cenamide. Dopamine agonist, 3 currently available in Malaysia, which is Piribedil, Pramipexole, and Ropinirole. The others is MAO-B inhibitor, which is and the other one is because the non-motor symptoms is actually can manifest from the neuropsychiatric symptoms, sleep disorder, autonomic symptoms, GI symptoms, sensory symptoms, and also other symptoms. But the most common 4 symptoms that usually asked during our review is actually first GI, which is constipation. Second is sleep, which is REM sleep behavior disorder or any insomnia. Third one is presence of any hallucination or not. And fourth one is the memory of the patient cognitive. It is symptomatic. So once patient is having all the symptoms, patient actually. So far, if patient only having psychosis untuk start. So there is a treatment, medical, drugs, medication. So based on Parkinson Foundation, so Parkinson Foundation is actually had been promoted and had been helping by our pelakon actor Michael J. Fox yang berlakon Back to the Future. So Michael J. Fox was diagnosed to have a Parkinson disease, tapi he is good. He macam ni with the Parkinson Foundation and he in the Parkinson Foundation supaya all the therapy, all the research can be done. So usually kalau misal macam dulu tahun 2018 pun untuk genetic study in Malaysia pun, actually we get of dia punya budget tu is from the Parkinson Foundation. Okay, so actually other than dopaminergic therapy ni, there is a few approach that been studied. Is it there is a improvement of the Parkinsonism punya symptom ke tak in Parkinsonism? So only DBS approved by FDA, and other therapy is actually still having a variable result. And for dopamine cell growth factor administration pun currently only at a phase 1. Tapi we should not macam putus asa. We still must go. So our scientists still go with all the researchers, and hopefully in the future we have a better management untuk Parkinson, and hopefully can have a treatment to cure the disease rather than to reduce the symptoms only. Okay, so I want to talk a few slides regarding the deep brain stimulation. So we don't have a neurosurgeon in our hospital, maybe because kita dekat dengan HSN pun. Because there is a neurosurgeon in Hosi. Itu tak puas hati. So deep brain stimulation is done by a neurosurgeon. So when we decide patient on deep brain stimulation, first we must do a levodopa challenge test. So in our patient in HRPZ, we did refer to the HSM. So HSM ada Prof. Saniha ada kat sini? Tak ada. So Prof. Saniha, neurologist there. So do the levodopa challenge test, and then they work out with the team of the neurosurgery. So deep brain stimulation is actually an operation to insert an electrode. By stereotactic brain surgery, the electrode was go through cerebral cortex, corona radiata, and aim the tip at the subthalamic nucleus. Okay. After that, there is a connection that we tunneling below the subcutaneously, and then connect to the battery at the anterior chest wall. Okay. So usually, when we want to refer patient for deep brain stimulation, yes, our population, even lambah panca pun difficult to get and consented. Lagilah operation yang melibatkan otak. Kan? So memang dia termenung lama lah kalau bila kita cakap nak bedah otak. Okay. So at the moment, the indication for DBS, when the presence of motor response complication, which are prolonged off, and also dyskinesia. The second one, if patient is actually already control other symptoms, however, still persistent to have a refractory tremor, not improved with all other medications. So when we talk about a surgical procedure, yes, we must also explain regarding the complication of the procedure. So the procedure can be having a side effect related to the surgical itself, related to the electrode, and also the complication when we adjust the electrode and when we titrate up the stimulation of the electrodes. Okay, so surgical complication related to surgical events is actually about 0.6 to 5%. Yang tingginya hanyalah infection, which is 5 to 6%. So other side effects only around 1%. How about the electrode? Electrode tu ialah boleh fracture, boleh misplace. Some patient had an allergy to the electrode. So in only about less than 4%. When there is, we stimulate the electrode with and also when patient was put on DBS, after wound is healed around 1 month into, so we call patient and we start to stimulate the area using dia ada macam phone gitu untuk kita gerakan elektrod tu to get better movement of the patient. So during the stimulation tu, some patient will have a few side effects such as paresthesia, dysarthria. So when patient is having the side effect, then we need to reduce the stimulations. So luckily we can get this April month to present on CME on Parkinson disease, because April is a Parkinson awareness month and tomorrow is a World Parkinson Day. Okay, ada apa soalan ke?
Any question from the audience?
So after this CME, we will do a Parkinson disease course.
Kalau ada soalan boleh ke depan.
And I really appreciate the Kelantan punya doctors, FMS support the course, because initially we only limited the 100 participant only. However, keep asking, so we extend to 150. Tahu cukup ke Dr. Damon?
Saya perkenal saya untuk titik. So basically, sekarang by 2030 kan, kita jadi geriatric punya agak aging kan
Aging.
kan. So basically banyak kes yang fracture, yang aging ni bila kita tengok kat klinik pun memang saya banyak tengok lah yang P-rolling semua tu. Is it pathonomony tu? Is it the pathonomony for the ni kita buat blood test positif semua. Dan satu lagi treatment tu, is it kita boleh start terus ke atau memang nak kena refer? Because you kata dekat district pun dah boleh. Lepas tu satu lagi ada kes yang rambut yang kita refer kepada medical, dia sebab CT brain dulu semua. In fact, saya nak tengok lah CT brain lah, MRI kan, satu macam quite weird lah for me. Sebab macam cakap tak ada investigation yang boleh, ni lah.
So kalau misalnya, that's why, so sebab tu kena increase awareness, increase awareness. Okay. So first of all, yes, diagnosis of Parkinson disease is by clinical diagnosis. So kalau macam Mr. Nazir kata memang dia punya features tu, kalau kira ada presence of tremor, glabellar positive, then usually need to refer to medical, is actually to establish other signs of Parkinson disease lah. Okay. So dari segi treatment, is actually the Madopa is actually already available in all klinik kesihatan. Madopa, only Madopa kan. So kalau Sinemet tak ada dengan dopamine agonist. So anyone can start a Madopa. Cuma nak start Madopa tu yang kita orang risau. Sebab sepatutnya Madopa start low, go slow. First tablet start 1 quarter. Biasanya dekat KK terus start dengan half the dose, which is 125 mg and then TDS. So when we start patient with a high dose dengan increase to 3 times per day, so the patient maybe not tolerate. So bila dia tak tolerate, the patient refuse to take the medication. Sedangkan the medication is so good to the patient. That's why we need to start low dose. So low dose tu is actually bukan nak reduce all the symptoms. We want to see whether the patient is tolerate or not tolerate with that medication. Imaging. So kalau CT scan semua tu, saya tak tahulah. Maybe dia tak discuss dengan neurologist ke ataupun physician. Usually, kalau order imaging is actually to exclude a secondary Parkinsonism. The most common is vascular Parkinsonism. So for those patients yang macam ada diabetic, hypertension, IHD, CKD, probably that patient need a CT first. Tapi kalau tak ada macam reflector untuk cardiovascular reflector, then doesn't have to do a CT brain or MRI.
Pasal patient yang let's say my fracture, so kita nak early ambulation kan, early ambulation. So basically untuk case yang Parkinson, so risk of fall dia tinggi kan because of the dementia, rigidity semua. So kalau kita let's say kita dah buat total hip replacement per se kan. So kalau dia jatuh pula, dia akan fracture peri, prostetik yang memang lagi itu
Saya rasa kalau misalnya fracture, usually kalau elderly, ortho ada apa conjoin dengan Jerry ke? Sebab Jerry also been trained for Parkinson disease. Kita just tak ada, Dr. Ho ada.
Bila you nak bagi patient tu berjalan lah mesti ni. Sebab sekarang kita bagi terus jalan kan untuk patient ni. Terus sekarang bila kita start initiate treatment, so bila actually kita boleh bagi dia
Boleh berjalan after hip fracture punya implant.
sebab hip fracture ni
Depends on ortho.
kalau auto buat pagi petang dia jalan lah.
Boleh.
Kan?
Tapi ialah bila kita start nak berjalan, bila kita advise patient untuk berjalan, tak semestinya patient fracture pun, patient stroke ke apa. So we actually must teach the patient how to initiate the movement and how they want to walk with their disability. So that's why in our hospital we have a good okay, Dr. Ho dah jawab lepas ni. Let me finish first. Okay. So we have a good team support, which is our rehab team. Okay. So actually the rehab team is actually doktor neurologist, tak erti. Wacik berdiri dulu ke, angkat kain ke. I tak belajar benda tu. So usually we refer to the rehab. So rehab, they know how they want to facilitate the patient or teach the patient how they want to walk with their disability. Okay.
Hi, good morning, everyone. I'm Ho, I'm the geriatrician this hospital together with Dr. Hughes. So, geriatric working closely with our orthopedic colleague in management of the geriatric hip fracture. So, I think if a patient with Parkinson disease after they have sustained hip fracture, of course, the risk of subsequent fall is very high. So, usually we will individualize and we will assess the patient whether the fall risk is high or is there any medication adjustment we can be done so before we can allow the patient to walk. So I think we in the future we will work together closely with orthopedic colleague and the rehab colleague. So thank you.
Ya, Datuk.
Saya balik pada staffness tadi. Lepas DBS treatment remarkable the improvement is very remarkable. But it 10 years, there is the chronology of the disease 10 years. So to have the DBS be prescribed earlier, and what it was the cost of the DBS? Is expensive. I mean, kalau kita tengok the improvement of the staffness, it's very dramatic. Daripada berjalan.
So actually, because it's really expensive. Dia punya cost, boleh beli apa? Boleh beli CRV. Tak. Kalau inta tak dalam 200 lah, 200K. CRV So that's why the DBS is not the first line of therapy. Tapi waktu saya train dekat UMMC, there is a patient, dia makan ubat di Wadopa tak improve, and then kita try dengan dopamine agonist pun tak patient cannot tolerate. So actually the patient opted for DBS at early initiation. So one of the treatment kalau patient yang memang tak boleh tolerate with all the dopaminergic therapy is actually DBS. Tapi ialah kita kan nak dapat 5,000 susah. Tapi because that is toughness, so at least kita boleh under GPA kan.
Assalamualaikum. I just nak respond on Naziri comment on bila refer buat macam-macam. So basically when it comes to Parkinson disease, it can be Parkinson-like. So that's the reason why kita start for investigation. But if you're confident enough with this Parkinson and shouldn't have any imaging, then maybe you should refer to the subspecialty rather than depend on my medical officer. Bukan nak defend the orang, because sometimes medical ni diagnosis of exclusion. So it's important to exclude before kita dah ni. So bagi saya, kalau saya mengajar, saya biasanya don't be too happy of diagnosing, but be very worried if you misdiagnose.
Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Nur Salam, Medical Officer from Psychiatry Department lah. So of course, from Psychiatry Department, I'm interested when Dr. Saidatul mentioned about the complication of the Parkinson disease is psychosis, right? So my first question, is the psychosis occur because of progressive of the Parkinson disease or because of side effect of the Madopa medication? It is dopamine agonist, right? And then my second question is in terms of managing the psychosis in Parkinson disease, it is we adding the dopamine antagonist, which is antipsychotic, together with dopamine agonist, or we can consider to balance the dopamine agonist, which is the Madopa, need to reduce the dosing or something like that. Thank you.
So actually, for psychosis, it's actually bila kita cakap pasal Parkinson disease punya symptom, it's not just a motor symptom, ia ada juga non-motor symptoms. So psychosis is actually a non-motor symptoms of Parkinson disease. Yang usually kalau psychosis related to the medication is more on macam attain. So kalau levodopa, dopamine agonist, I rasa my literature review tak ada yang menyebabkan psychosis. So usually kalau patient ada psychosis, first of all, the psychosis will be occur in kita kata bukan in earlier diagnosis. Mungkin dalam 3 to 5 years later after the diagnosis. Kalau misalnya related dengan medication, kita start je ubat terus dapat psychosis. Okay. Yang kedua, bila patient ada psychosis, yes, we need to start a treatment untuk reduce the psychosis. To reduce the side effect of the antipsychotic, that's why the only antipsychotic that approved untuk Parkinson disease is quetiapine, Seroquel. Yang ada tak boleh minum sebab boleh worsen. Lagi juga.
So I think our presenter have 3 questions referred to our audience. Just one time, second raise your hand.
Tiga soalan. Okay.
Siapa nak jawab boleh terus angkat tangan.
Yang kata 3 soalan yang senang. 3 soalan yang senang kot. Senang untuk I, tak tahu senang untuk orang.
Siapa nak jawab angkat tangan.
Okay, soalan nombor 1. What are the clinical features of Parkinsonism? Tak nak tangan. Boleh hadir. Tremor lagi? Kenal banyak. Parkinsonism kan? Tremor, rigidity. Echinacea. P, postural instability. Okay, boleh. Yay. Okay, soalan nombor 2. Ada 2 lagi kan?
Ada 2.
Okay. What is gold standard therapy for Parkinson disease? Madopa. Okay. Dia levodopa base lah. It's either Madopa ataupun CME. Tapi sebab KK semua ada Madopa, so FMS, MO, Madopa. So CME hanya ada dekat HRPZ, dekat hospital. Okay, under neurologist. What surgical approach approved for PT? Siapa ni? Anila. Tak Anila. Baca nak because apa? Okay, so thank you for come today to support us. So kalau misalnya ada referral, so actually kalau case yang really specific to the neurology, it's better to refer terus to our neurology team because we also have 2 neurology MO. Currently Dr. Aida and Dr. Adira.
Thank you so much, Dr. Sedato Manero, for that insightful and eye-opening presentation. We truly appreciate your time and expertise in helping us understanding Parkinson's disease from a deeper perspective. Now, I would like to invite Dr. Izami to give a certificate of appreciation to our respected Tunisian presenter. Ladies and gentlemen, let us carry forward the knowledge shared today and work together in the innovation and their family. Thank you once again. So stay tuned for more interesting CME next session by Pete's department with the topic Adakah Anak Saya Bantut by Pete's Endocrinologist. With that, I close our seminar with Sarawak Hospital.
Okay. How do you think? Hello. Okay.
Kes lagi ke?
Hmm?
Kes lagi ke?
Kau nak guna ni?
Tak ada. Oh, boleh guna. Boleh sama.
Cik Zat guna hak ni kau guna komputer lain?
Pasti masuk lagi dah.
Oh, guna
Tak
komputer
apa.
ni?
Ni kau cuma masuk dah.
Guna komputer ni kau guna komputer lain? Nak untuk present.
Present rasa dia
Ni. Kat mana? Nak transfer.
rasa dia ada komputer lain.
Ada komputer lain. Oh, ingat kau guna hak ni? Sama Lina ni. Hak ni tak tahu. Hak sini dah. Ha. Kau nak guna lain eh?
Besar dia macam ni.
Guna saya nak guna tu.
Boleh kau nak kita ganti pakai ni deh. Kau tak ada. Kau
Boleh
dia ada
check,
backdrop.
Tak.
Ada backdrop ke?
Pinjam macam ni. Nak internet. Hak siapa ni? Hak siapa benar ni?
Asal tidak.
Hospital.
Ha?
Hospital kau.
Ha. Soal dia tu.
Hak CME. Dia gila. Okay, okay. Kejap, kejap. Tak kena nak hot saya download dekat YouTube dan nak masuk dalam saya punya slide dah ni. Tak jumpa cari dekat downloads. Dia tak tubik dalam download sebab ni. Tak masuk dalam slide saya. Apa dia? Oh, kau sebab ni download dalam YouTube ke?
Dalam ni guna laptop mana?
Oh, tak.
Oh, tu ada CME.
Tak. Saya nak masuk sikit video dalam slide saya.
Oh, tak ada slide. Masuk video daripada
YouTube.
ada link dia.
Ada.
Kau memang ada video.
Video. Kau masuk link sekarang.
Kalau ada video, awak masuk video dia. Kalau awak masuk link ni, dia atas kena guna lah. Video dia ada.
Oh ni? Tapi saya tak tahu.
Oh ya.
Saya nak masuk.
Oh ni. Video ni. Ni ya. Ni. Awak tu di luar dia. Oh. Tu di luar.
Oh, YouTube.
Belajar di luar. Belajar dalam bentuk video. Itu. Itu lagi.